Hello, everybody. We've been running group clinics for quite a number of years, and I just wanted to tell you a little bit about what we've been doing. I'm hoping that you can hear me okay. Um, so if I may move to, can I do the slides? Oh, lovely, thank you. This is what I'm going to cover. It was really why we actually moved to group consultations or group clinics. Our experience with them, how things with our QOF changed, patient care and staff experience, how we found them at the beginning, and what we kind of think the opportunities are moving forward. So if I can, next slide, please. This is why we moved to group clinics. So there were two of us that run diabetes clinics in the practice. Myself, and I'm a pharmacist, and Alison, who is our nurse prescriber. Oddly enough, we did our prescribing together, and so we kind of qualified about 20 years ago now, and started. I did hypertension initially, she did diabetes, and the two obviously have a huge crossover. And so we were sort of tasked with trying to manage the cohort of people in the practice with diabetes and hypertension. And so we teamed up, and it seemed that the whole week was full of people that you saw one-on-one, and the numbers just didn't seem to change. Next slide, please. What we found was the other way. So what we thought was that, I'll tell you a little bit about access and efficiency and how we've managed to get more in terms of our time spent doing things, how it's affected our patient outcomes, how we personally feel about what we do, and a little bit, I suppose, because I'm a pharmacist, how could I do without medicines optimization? A little bit about that and what we've found across the years. Next slide, please, Leisha. So, as I said, it found like the week was full of diabetes clinics. And what we found was that actually we kind of went cold turkey. Okay. We decided, we had a little glimpse of what group clinics could be like in 2016. And then we decided, it took us 2 years to work up the courage to go, okay, this is what we're going to do from now. And so we decided that we were not going to really offer one-to-one appointments. We were going to offer group clinics for everybody. There were a few exceptions, people with psychoses or people with learning disabilities that we felt couldn't manage the group. So we ran one face-to-face clinic, and the rest of the cohort of people actually went into group clinics, okay, because we'd never done them before. So what we found was that we freed up basically loads of time, okay, and it's on the slide there, but actually, that's half a clinician's time a week. So what we thought was, well, if we go to this model, we're going to save time, and we're not going to be saying the same things, and it reduced the waiting time, because if patients had their blood tests in the one appointment with the HCA, then the follow-up was actually much quicker. Okay, and so what we found was that our weight dropped, and there was initially a reluctance for people to actually come into the group clinics, but actually we spoke to them and said, well, look, actually, unless you try it, how do you know? Our group clinics we ran one in the morning and one in the afternoon on 2 different days of the week. Originally, we started with 4, but we moved down to 2 because that seemed a good number to go down. And so what we found was that actually our group clinics really took off. They were full of people in terms of who was there, who was coming. And even the most reluctant people at least tried one. And I'll show you some data in a bit. The DNA rate didn't matter. Whereas in a one-to-one appointment, if you've got clinicians who've got booked appointments, as well as I do, it's really frustrating because you've got a snippet of time, but you can't actually put your teeth into anything. The other thing we noticed, and this is just like recently, what we noticed was there's still Alison and I doing diabetes, But actually, across the country, people with diabetes has increased because of the obesity epidemic. So what we've noticed is it's just us two still providing the care, okay, but our cohort has grown. And I guess I can only tell you that by doing this in a group setting, what you'll find is that actually you can still manage that. Next slide, please. So patient outcomes. When we and we still do this, we still check with our patients what they think about what we're offering them in terms of the information that they get and how much they understand about their condition. When we first started in 2018, what we found was that actually people didn't really understand what HbA1c was. And that's really galling when you spend all day, every day talking to them about their diabetes. Like, what is that? What does it mean? Now they do. And so the conversations have moved on a little. We found that actually there was peer support, empathy, and challenge from each other within the group. I don't have to speak as much, they speak to each other. And it's almost like a peer support network that actually they challenge each other. And, I had one last night. I had a group clinic last night. So my group clinics run from 5 to 6 in the evening. So people that tell me they work can't escape me. But what we found was that half the people in the group, most of the people had had their flu vaccine, and there were a couple of people that hadn't. And it was quite interesting because the ones that didn't were asked by the people that did to actually have their flu. And it was a peer on peer conversation, which meant that actually they did have it. Whereas when we say it, it's less expected. Friendships have grown in the group. So I come with my friend because then we can have our appointments together, but actually it's quite a nice chat as well about what's going on. Social prescribing offers also got undertaken. And so for a little while, what we had was our social prescribers supporting when our receptionist was off ill. More personalised support and advice, not only from the clinician, but from each other. And also what we found was that actually there was higher expectations of their own involvement in care. So when you do a group consultation in the spirit of a group consultation, people don't actually then want group education. And we did a little experiment with IAPS, thinking that, everyone needs a bit of psychological support when you've got a long-term condition, but IAPS didn't run it the way that we were running individual group clinics. They ran it as a group education and the patients hated it. The other thing that we found was that actually the shift in self-care happens more in a peer-supported environment, okay? It's no longer the doctor or the nurse telling me what to do. It's actually, I can see for myself that I need to change things. And that shift in responsibility is really key if we're going to move to self-care and improving outcomes and people taking responsibility for their own health. Next slide, please. So the other thing that we found was that actually people were much more truthful about their medication taking. They asked deeper questions about what their tablets did. That also freed us from actually repeating it 16 times. So what we found was that actually, if we're talking about SGLT2s, what happens is that actually you can tell them the sick day rules and all of the stuff around SGLT2s, and everyone's heard it, and you said it once, not 16 times. The other thing that happened was that they thought that, in a way, what we found was when the facilitator was speaking to them, they would have conversations about their medicines, okay, with each other. For example, metformin causes me diarrhea, but I don't take it every day. So actually, that information then came back to me because the facilitator tells me that. So it gave me a new in to about what their numbers were and what the issues were about their medications. Because when you ask people, they don't always tell you. But if one brave soul in the group says that there's an issue, then you find that actually it's like a little cascade that everyone says, well, actually, I don't take this or I don't do that every day. I take it when I think it's the blood pressure's high, I'll take my blood pressure tablets then, and so forth. that gives us an opportunity to deprescribe. If you're not taking it, well, let's stop it and let's try something else. So in next slide, please. So this was really important to us because we were really fed up of these people that kept coming to our clinics, and actually it was just like we tried to do the best we could, but actually they just weren't getting it. What we found was that actually you spent an hour and a half talking to people about what really mattered to them and what was important in terms of their care of diabetes. What we found was that actually our facilitator, and this is what was really interesting. So initially we used our HCAs as our facilitators, but what we found was actually having the skills in different parts of our team, so our reception team and our HCA team, and putting them together in admin, we could actually spread the learning as a practice. Actually, this is really key to the way that we're working. So we need buy-in from everybody. So what we found was that actually we got all of our new receptionists always sit in a group clinic so they understand it. They then chose somebody from reception who actually knew the patients, right? So actually the sell is a lot easier. Our HCA team also were part of that because they do the checks. So then it became a much more slicker approach to actually making sure that people had had their blood tests all done, all their year of care bloods before they came to the group, and that actually the HCAs and the reception team knew that actually before they were having a group clinic appointment, all these things should be done. And so what we found was that actually I didn't need to worry too much about the results board because I knew that my team were actually going to make sure that all those results would be there. And so they take ownership now in producing that results board. So they've learned an awful lot in terms of not only diabetes, but also why it's important to have those checks. So actually it's a lot easier to sell. The other thing that we found was that actually they've grown in confidence, but also any new member of our team, be it clinical or admin, actually understands why we're doing what we're doing. The other thing that happens is when you have students or you have registrars or whatever, they come and sit in the group clinics because then they learn about long-term condition management. So it's a really good teaching training environment as well. So moving on. So this is our QOF data. You can see from the top headline, 2016, 6.3% of people on the register. Now, over 9%. Okay. Now, we couldn't sustain that if we didn't do group clinics with the workforce that we have. The numbers aren't fantastic. I work in a really deprived area. Okay. Diabetes and management of diabetes isn't the sole thing that people are interested in, but we try to make it relevant using that peer support network. You can see that we started at nearly 40%, everyone going through. And I haven't recorded it for 2016, 2018, because I didn't have that data, I didn't code it in a systematic way. But we have maintained a 30% uptake in group clinics. And we've got people that have been coming for about 3, 4, 5 years now that actually they like that approach because actually they're sharing their condition, they're sharing tips and tricks, and they find value in it. So it's a really, really powerful thing to be doing, and it saves us time, and we don't feel burnt out as a consequence. So you can see the other thing from that results board is that actually diabetes isn't obviously just a sugar thing. You're looking at blood pressure, you're looking at kidney disease, you're looking at statin uptakes. Okay. And so all of those things you address in a group clinic at the same time. It's not just unilateral, just let's focus on, what are your blood sugar results? Let's see what's happening. Next slide, please. So opportunities. So it's barn door obvious, but I just thought I'd put it on one slide. Those are the things that I think really are important, that actually you free up clinician capacity, you find an alternative use for your skilled staff. Alison fits coils, okay? She is valuable. I don't want to say any more than that. All of us that are doing these clinical processes, we want to learn more and offer our patients more. So actually, you've got to have time to do that. Your processes improve. Okay, so your 9 care processes for diabetes will improve if you systematize what you're doing. And also, your staff satisfaction will really improve because actually people feel part of the process. They really enjoy it. You're doing something different for an hour, hour and a half, and actually you're learning an awful lot more. So the team really know that they understand what wicked disease diabetes is, and it's a team approach. And if there are things missing, say for example the patient didn't turn up and the foot check needed or the flu jab needed to be given, you can do it in the group clinic. You can do 9 or 10 people in a go if 9 or 10 people haven't had a particular thing done, for example, flu. So we take our flu vaccines up to our room where we do our group consultations, and they roll up their arms and they have their flu vaccines at the same time. So you're saving time, saving appointments. Last slide, and then I'll stop and you can ask me millions of questions. So system benefits. So for the system, it really is time efficient use of resources. We've also done a hybrid clinic where we've done face-to-face and Teams. You've got to have the right setup, but actually it's an opportunity for people that aren't able to come in to join. Okay, so if you're smart and you've got a good projector, a good room, it's really quite beneficial, and people can feel part of the process with all the caveats that Alicia said before. Comorbidity, we're treating them holistically as people, not as a disease. Okay, because you hear the stories, and we've had people tell us about safeguarding issues, domestic violence and stuff like that. It's an opportunity to involve other staff within the team. Okay, so facilitation is key. So who does facilitation? Health coaches. Other people can do that if the practice hasn't got sufficient resource, if the PCN can support it. When we're thinking of the 10-year plan, just think about how you can actually involve community specialists. If you have, a group of patients who you don't know quite what to do with, and you think, well, actually, I need to refer them. Well, the opportunity is here actually to think about how you can actually do that in a much more slicker way. And you can see people's faces light up. There's nothing more rewarding than actually seeing when patients get it, and actually they take that ownership upon themselves. So for me, it's kind of the best thing that I've done in terms of patient facing work. It's a real opportunity to be able to do things in a different way that involves your team and makes you feel really good inside. I hate one-to-one consulting because I just don't think it offers the benefits that we've described, and also that peer-on-peer support. So I think that's my last slide. Yes, thank you for listening.
Brilliant. So we've got 3 questions. They're pretty quick ones, I think, for you to answer, Dipti, because we want to move on to overcoming the barriers, and then there'll be a lot more opportunity for you to share your experiences. But just in terms of the questions we've got, do you do your foot checks before or during the group clinic?
So I think we try to do them before. We try to do everything before, but if somebody's missed something, they can have it done there.
Yeah, brilliant, fantastic. So generally speaking, the HTA appointment, they'll get all their bloods done, all those other things done, so it's all ready for when they have their clinical review, which this is. Yeah. How long does the admin take? People are worried about the documenting it, that it's going to be loads of extra work, filling out templates for all those patients. What's your efficient process that you use?
So there's quite a number of quick cuts, because you can set up key things that you're going to say. You're going to talk about diet, you're going to talk about exercise, you're going to talk about blood glucose monitoring. All of those things are quick keys that you can set up. I think, to be honest, the admin is almost identical, if not less, because some of those things are streamlined. You're going to be putting those things in anyway. It's not like it's any different. And so some of it's repetitive. So it's just thinking about, actually, can you do that in a much more slicker way?
Yeah. and people can, I mean, often you can also get your facilitator to help with
Yeah,
some of that, so they
right.
can do half of the documenting, and then you just go and do your clinical tasks that you've got to follow up, like changing medication and stuff
Yes,
for each,
that's
just
right.
as you would do normally. Okay, brilliant. And then finally, how about timings, scheduling so that people can attend? So you mentioned obviously that you do one at 5 o'clock in the evening for people who are working. How do you guys, what have you guys learned about scheduling and to find times that work for everyone?
So I think personally, it's not for everyone. I mean, 30% uptake, okay, but what you do is actually offer choice. So we do one at 10 o'clock in the morning and one at 5 o'clock in the evening. And people have a choice of booking into either. Also, it's which clinician they're used to seeing, right? So if all your clinicians do it, then what you find is that actually, you know, they've got the choice of clinician for longer that actually they can book in with. They will make the time to come. They absolutely love coming. So from that perspective, it's not there's not ever going to be a right thing. Just go with what you think, one in the morning, one in the evening, and you can always mutate it. You can always change it if you find that that's not suitable.
Yeah, brilliant, fantastic. Okay, so we're going to move on now. If you've got other questions, do pop them into the chat. We'll come back to them if we can. I'm just conscious of time, and I want to make sure that you go away feeling empowered to actually get going with group clinics, having those discussions, getting your team engaged. So that's going to be our focus for the rest of the webinar. So if we could take the next slide, please. So I would like you to post into the chat now which of these is most aligned with your particular situation right now. So if it's A, I'm keen, but other people in my practice are skeptical, put A in the chat. If it's B, we all want to progress, we just can't access funded training. We are all interested and other issues are just more urgent. Or if it's something else, put D and tell us what that thing is. So we've got quite a lot of people struggling with engaging other colleagues. Yeah, so that's interesting to see, and that is often the case, that you guys are kind of feel like the lone wolves a little bit in your practice, and you are kind of like, if you could only get other people on boards, that would be great. So it might also be worth popping in the chat for us as well, whereabouts whereabouts you are in terms of what are the things that people are saying to you? What are the kind of concerns that people are raising around group clinics? Those of you who are A's, that would be really useful to know. If you haven't got access to funding and you want to talk to us about that outside of the workshop today, just pop your email into the chat and we will pick up with you around that and help you to think about how you might be able to access that training. The training is actually potentially something that you can get funded even at a PCN level, because the entry level is really quite low. It's just £200 per person, although we think you need 6 people to get trained. So we'll talk to you about that a bit at the end as well. So that's really helpful. So just taking a look at that. So concerns around onboarding patients, funding training, time to set them up. Time is always going to be a big issue for you guys right now, but that, despite that, you've heard from Dipti how much time it saves in the long run. They don't see how it would work for us, wouldn't know where to start, don't see how it would meet QOF. Okay, that's a good one. So Lisa, hopefully you've got a good bit of evidence from today to show them how well it actually meets QOF. And we're going to send out a paper that Dipti and I wrote that actually summarises a lot of the evidence Dipti shared with you, which you can use as evidence to show that it really does deliver QOF. Okay, let's move on. We've got a feel for the room. Pop it. Anyone who wants to follow up about training, pop it into the chat. Just chat. Putting your email will let us know that you want help with that. So, in terms of critical success factors around getting going with group clinics, these are the things that we know work. And we've had these same critical success factors now, by the way, for 10 years. So they really are the things that matter. So the first thing is you must get a strong leadership team within your organization or your practice. In general practice, that's going to be a GP who's a partner or who's got some power. Dipti didn't mention to you perhaps that she is actually a managing partner, so she's been able to champion this herself in her practice. But getting a GP on board who's got a bit of power and influence in your practice is really, really important. And also your practice manager. This not gonna work without them. You need to have an effective plan, be organised, know why you're making this change. Our learning programme has also got a route map that breaks down the change of moving from not doing group clinics to group clinics into 7 easy steps that you need to follow with tasks within those steps. And we walk you through the planning process. You need the right space. So you might want to do face-to-face group clinics. That might be what your patients, what you as a team would feel most comfortable with, but you might not have the right space for that. So you might need to look at video group clinics. You have to be a bit pragmatic around that. Or, you might be able to work in partnership with a local community organisation who might have a space that you could do your group clinics from. You don't need to do them from CQC approved premises. So that's all good. Can I check that you can hear me all right? Because somebody put voice gone in the.
I can hear you, Georgina.
You can. Okay, that's fine. We also need to make some changes to the admin process. We walk you through all of that. And most importantly is having a compelling story for your patients that gets them interested in signing up. And we know there's some very clear best practice around that, which is contained in our toolkit. And one of those things is creating testimonials. So there's some lovely testimonials on our website from Dipti's practice of patients talking about their experiences of group clinics. And it's quite hard when you listen to that to actually think they're talking about a medical appointment. It's had such a big impact. So you need to create some little testimonials from your patients, which will also help get those skeptical people on board. Then you need to focus on your workload priorities in primary care. That's going to be QOF, and also accessing training so that you can actually learn how to facilitate and set up and run group clinics, and having clearly defined roles within the team of who's doing what are also really, really important. Okay, so if you get those things right, you're going to succeed. Sandra, I've just noticed that you've popped a D into the chat, and D was other. So tell us in the chat what your issues are in Orpington around getting group clinics going, and we might be able to help with that. So the next little challenge to you guys is let us know what you want to know. So this is a topic board. Remember that Alicia shared a topic board with you earlier as something that we use in a group clinic to get the group to share with us some of the challenges, some of the concerns that they have. So we're modeling the process a little bit here in our masterclass, and these are the challenges that we know people often have around getting going with group clinics. So we want you to post your questions in the chat, stimulated by this topic board that you would like Dipti to help you with today. So is it around how to use the evidence base? Is it about how to make the case for funding for your training or for other things that you might feel that you need? In terms of engaging skeptical colleagues, tell us a bit more about that. Is it, my practice manager can't get her head around it, or or my lead GP is really skeptical and says there's no evidence to support it. So tell us exactly what the kind of objections are that people have got. Is it that you just aren't making group clinics a practice team priority? Dipti can help you to think about how to make it a higher priority within the team. creating the headspace for change, always a challenge in primary care. As Katie says, the workload is so overwhelming. It's hard to get people to think about doing innovative things. So yeah, absolutely, we get that. Or is there something else? Is there something else that you're dealing with that you want to bring up? Okay, so we want a bit more specific. So Kirsty, rather than making it a priority, give us a little bit more context so that we can help you with that. And we're just going to give you a couple of minutes to post those questions. And then what I'm going to do is, as the facilitator today, so to speak, for this little session, I will kind of feed some of those questions to Dipti, and we'll kind of take some of them in a kind of themed way. Okay. So the PCM, we've got one from Deborah here from Christchurch. The PCM board want more idea guidance on the structure of how they would look and how to set them up before they'll agree to try them. Okay, Deborah, that's interesting. So let's see what resources we can signpost you to. In fact, I've got a little, I'm thinking we're going to respond to that straight away. And car park, it is a video group clinic, but we've got actually a little 4-minute animation that explains how video group clinics flow, which would be perfect for you to share with the PCN about that. We'll send that through to you. Okay, so let's have a look at these questions. So we've got the workloads are overwhelming. It's hard to get anyone to think about doing anything new. We've got making group clinics a priority, as sort of related to that as well. Okay, so let's take that one as the first one, Dipti. So in terms of making group clinics a priority, when we're so busy, sort of creating the headspace, what would be your thoughts and reflections on that one?
So I guess it's really, you can see the benefits. So it's about the nitty-gritty. What is it that I need to do to actually facilitate that change? So if I think of that, that it's going to release time once you get it going. So it's actually about, how do I set it up? And who do I get involved? Who are the key people that I need to get on board? And it might be that you start with a small disease area where you've got a long wait. So it could be, diabetes or what have you. So I can say to you that actually, who are the key people that deliver the care? Are they interested in working in a different way? Because then what you do is block all their clinics moving forward and actually plan the clinics in a group way, so that actually you're ready to deliver them. How are you going to get the bookings in to those group clinics and set them up? Who needs to be involved in doing that? And what is it that they need to be confident in saying to the patients that they're going to be booking in? So there are some key things that you kind of need to have thought about. And, that's not a lot of thinking to create all that space. And I know it's busy, but it's just, you just need to think who, how, what, where, really, and then plan that. And I think your practice manager will support you to do that if they can see that actually it's going to release. I mean, that's what happened with us. It released a whole session of somebody to be able to do something that brought income in. So we're talking about money.
I think you're right. That people do need to understand some of the practicalities, but I think there needs to, there's something about using the evidence, isn't there, to make the case. So, we said we're going to send out this paper that summarizes and is a peer-reviewed research paper that Dipti and I wrote. So that first thing I would recommend is use that, and enlist the support. Rosie is one of our practice managers who's on our program, and she said your practice managers are on board. If you can take work away from them, so I think the practice manager is a really good place to start, because they will understand some of the really quantifiable benefits, won't they, that you found from how this has impacted your practice. They know that if they can if they can invest a bit of, if group clinics can lead to a zero 0.5 full-time equivalent nurse post being freed up for diabetes, when you're only doing 30% of your patients as group clinics, that's massive. So start with the practice manager and get them on board, and then work with them to get other people in the practice on board as well. And as you say, Dipti, find those supporters, those clinicians who are willing to give it a go. I mean, I think it's okay to share, isn't it, that your nurse wasn't completely convinced in the beginning, was she?
No, she wasn't, bless her. And it was kind of like, oh, I don't think I can do this. And I was like, okay, well, you don't have to. I'll do it. And then
Yeah.
once she started doing it, she's done a complete U-turn. It's the best thing she's done. She hates doing one-to-ones like I do. So it's actually, you know, it go with the willing and start doing what you can, and then it will build momentum.
Yeah, absolutely. So it's interesting. Joanne said winter pressures take precedence, and yet, we've heard from Dipti how the group clinic model can actually help you to address winter pressures, make sure the right people get their flu jabs and stuff. So, but I get where you're coming through. This might not be the time of the year to be like going to implement group clinics. However, think about the new year. It will take you that much time to get going. So it's worth starting the conversations now on the back of what you hear today. Francine's also popped in that they've had we are a community organisation running a monthly diabetes support group who got funding from public health. So public health is a great place to look for funding to support you with this. I think that it's making links with public health is a really good idea, getting your PCN to do that. And she also mentions the health equity fellows. So get in touch with your training hub and see whether you've got any fellowships that someone from your team might be able to apply for that would give you some of that funded headspace. Quite often with a fellowship, you get like a day of backfill a week or a session of backfill a week that you can use, and that person could then use that time to help them to set up group clinics. That's a really great piece of advice, Francine. Thank you. Okay, brilliant. So Jane says as well, it's a question about releasing members of staff to complete training. So just to say on that front, ELC absolutely understands that. So our training is self-study, and each little section takes 20 minutes, so that that training can be completed in between other clinical stuff, and you don't necessarily need to take people completely off the job to do the training. They could do it over several weeks, a little 20-minute slot a day or something. So those issues can be overcome, Jane, in terms of training. Right, I'm gonna just check through the things again and look for our next little theme. So we've got, yeah, a lot of it is actually about making it a priority when I look at this. Lack of funding. So is there anything else, Dipti, that you could advise people about funding where you have a bit of an overview of the system right now? You're not just working in your own practice, you work at ICB level as well. Where would you advise teams on the call today to maybe start some conversations about where they could get funding for training, and for to support making the change?
I think you've mentioned it, that I mean training hubs. You've talked about public health, and the other place is actually at a PCN level, thinking about what the PCNs hold and the capacities that they have, because actually the bigger this goes, the more efficiencies you're going to release. And so part of it is actually, have a chat with your PCN, because if you can do it with some support from them, And it's not just about the money, it's also about the resource. So they've got lots of staff that actually lend themselves to facilitation roles here, but also they've got a whole group of, pharmacists or dietitians or whatever, because actually it means that they're employing them and they can use that resource to support or augment the group clinics in a certain way.
Mm-hmm. So we've got a comment from Diane who about making group clinics a priority because she's a health and wellbeing coach for 7 surgeries and she could use her time so much better if she was running group clinics. You're absolutely right, Diane. You could, and that I think is a conversation with your PCN line manager, really, isn't it? But bear in mind that you can't do this on your own. You do need admin support. You need a facilitator to work with you. So yeah, that's a classic example, isn't it, of how we could be really leveraging our workforce so much better. Do you face this as well? Katie said PCNs are really reluctant to do anything new at the moment as their future is so uncertain beyond March. What's your reflections on that, Dipti?
So I don't think that the future is uncertain beyond March. I haven't seen anything. I know neighbourhoods are coming, but I don't think that actually PCNs are going to disappear necessarily. But there's a whole load of usually ours underspend that now we're getting to the last 6 months of the year. Actually, you can tap into that and actually give them a plan for something that they can actually use that underspend for. So that would be
Amazing.
my view on that.
Yeah, and I can absolutely back up that actually. And I'll tell you the role that you ought to get funded, and it's a care coordinator. And if they get a care coordinator funded, that is also a key role in delivering neighbourhood health. So it'd be a double whammy because the neighbourhood health model specifies that care coordinators will be central to its delivery. So Katie, go to the PCN, talk to them about the evidence base for group clinics. So if we get a care coordinator on board, we can actually, they can drive the introduction of group clinics, and it will put us in good stead because it'll actually mean that we've got a care coordinator who could drive neighbourhood health, which will be the next thing next year. So there's a really great tip. Love that. Can we move on a little bit, if that's okay, from the slide point of view? So what we did was to just put together a few slides to get around getting going with group clinics, some enablers and some advice that we might not have covered yet in this interactive session. And we've just got about 10 minutes left, so want to make sure we get through that. So let's go through these enablers. So the first one is use the existing evidence to support the change. So this is there is no other intervention in primary care that has the evidence base that group clinics have in terms of innovation. There are 15 systematic reviews directly comparing group clinics with one-to-one appointments. That's the most high quality type of evidence that exists. And the strongest evidence base is in diabetes, as you've heard from Dipti, her lived experience, but also we have a study that backs that up. The research consistently shows high staff and patient satisfaction, quality of care sustaining, productivity gains, reduced waiting, and appointments being freed up. Given the challenges we have in primary care, there is a strong case for using this. And we have a slide set and an evidence summary. And if you don't mind car parking this, Alicia, we will send those out to you all after the session as well. Okay, next slide. The second thing is look for funding. Be aware that funding is available despite what anyone might tell you. It's just a question of tapping into it. So there is potentially funding available. A lot of people do their group clinics in extended hours. Dipti, does your 5 o'clock clinic count as extended hours, or is it still
No, it
normal
can.
hours?
Anything after
Yes.
4:30 you can bid for, can't you?
Yeah, so So there's extra money for extended hours. So if you do group clinics in your extended hours, you can get funding to support that. Make the link with QOF. So Dipti's work has increased her QOF achievement in the early first 18 months. It actually led to an 18% increase in QOF. So that's a really good argument to use. You can also look at locally commissioned services. So, for instance, in Devon, where we've done a lot of work, the public health team have been paying GPs to do health checks. You could do group health checks. There's also lots of funding around linked to health inequalities, which you can access through public health, but also through the ICB. So ask some questions. Coming up to winter, you could actually look at winter pressure monies and use those. And as Dipti says, we're 6 months through the year. There's often underspends, particularly in ours. So make sure that you explore those. And if you want help and support around making a business case, get in touch with us and we will pick that up with you and help you to make the case for funding. If you find some money, we'll help you to bid for it. Okay, next slide, please. You mentioned the R's monies, look at those fellowships, contact your training hub, and also think about partners in delivery. Could you be asking local charities to work with you? Sometimes NHS trusts have charities you can apply to if you work in a trust environment. So, you know, I've worked with several trusts who have applied to their charities to fund training. So there are sources of support, and we need to tap into them. Next slide, please. So just to also say that if you get any pushback about whether this is relevant, group clinics are mentioned specifically as part of modern general practice in this publication, How to Improve Care-Related Processes. They're talked about, they're referred to as shared medical appointments, but they're very much in the mix. Next slide. So we'll step over that one. I'm not sure we've got anyone from collective care. They also deliver the 3 shifts very effectively in the 10-year plan. And let's make a note, Alicia, to send out the executive briefing from NHS England on how group clinics deliver the 10-year plan as well. So we'll send that out as a little resource to you too. Thank you. This is what I'm talking about. This is a report from NHS England, which was developed by all of these directorates. So it's a great one to use with your ICB as an evidence that this is a good thing to do. And it sets out basically the case for investing in group clinics. So definitely have a look at that. So in terms of engaging skeptical colleagues, we've already said it, but just to remind you again, it's really important to get that senior clinician and practice manager on board first. Put all of your efforts into that. Once you've got them supporting you, you can move from there. But if you don't get their support, it's not going to happen. Find out what matters to each of them. So for a senior clinician, they might be concerned about consent and confidentiality for patients, whether patients will engage. So you can use the evidence base we send you to really focus on that. If it's your practice manager, they're going to be thinking about QOF and that kind of thing. So you've got evidence in relation to that as well. Get them to come along to one of our webinars that we run on a monthly basis so that they can hear about people's experience talking about this. We've got all of our webinars for next year already on our website. So, you know, perhaps you can get them along to the January one. And after, do a bit of digging to find out what local support you can tap into so that and use that as a way of getting them on board too. Maybe you also want to contact some local pioneers, particularly if you know that your GP partners respect and know that practice. We know who the pioneers are in your ICB, so get in touch with us and we'll help you to find them. So, Dipti, anything else that you would add around skeptical colleagues to that list? Anything else that's worked for you?
So no, not really. I mean, that sounds like getting the support is really key, and using the evidence as you've said, and actually finding what that person's interested in. Because
Yeah,
you can bet your bottom dollar that group clinics is going to cover one of those things. If it's about money, you know that the resources are freed up to deliver an income stream in a different way. So
yeah,
that's usually what GPs are interested in, particularly GP partners, because you've got to make the books balance, right? So
absolutely.
it's finding the hook.
Yeah, absolutely. I think we there was a really nice thing on one of our webinars where it's like define a problem that needs solving and use group clinics. So you had your problem, which was, we're just doing diabetes all day, and it's, it's exhausting. That was your problem at the time, wasn't it? It might be, we're just not getting through our diabetes cough. That would be a great hook to take to the practice manager and say, let's do group clinics, because otherwise we're never going to achieve this quaff. Those are the kind of conversations that can be really powerful, aren't they? So, thinking about those skeptical colleagues, we've got, the sort of objections that we know people come up with. Nurses often say things like, I can't provide personalized care in a group. My patients are really complex. They may be worried about whether their clinical knowledge is actually up to being in a group with a group of patients. If it is, that's really important to know, because actually we need to do something about that. We can't hide in our one-to-ones, can we? If we're not feeling confident about our clinical knowledge, we need to use that as a little opportunity to get up to speed. People often also say, can I observe one? Part of our training is simulation training, and that gives you the chance to be a fly on the wall at a group clinic that is modelled for you. So that's really important, that you let your colleagues know you will get simulation training as part of the support that is on offer. Clinical people often worry about confidentiality. That's all covered with NHS England signed off processes. We've talked about the importance of sharing the evidence with your clinical lead, and you can demonstrate that it is going to help to meet QoF targets using that evidence. Okay, next slide. Practice managers, is it a lot of extra admin work for the team? The answer to that is not, if you follow the best practice, which is in the training and route map that we provide. Are we getting paid extra? No, but you're improving your productivity by doing group clinics. Yes, it will deliver GMS for you and QoF. And is it part of modern general practice? We've shared with you. Yes, it is. The reception team and HCA team, really important to get them on board. We find that the best way to do that is to involve them early, make sure they get access to training, particularly if they're going to be working with you on the admin side. And we need to help them to get a story for patients that they feel comfortable telling. A great way to do that is actually to involve them in your dry run when you do that, and make them patients in your dry run so they can actually experience a group clinic. Next slide. Okay, so if in terms of group clinics, we've actually just recently done an audit, and our coverage of QoF, Alicia, remind me, is it now 75% or 70% of QoF that we
It's
cover?
75%.
Okay, so 75% of QoF, we've got tried and tested templates that you can use to deliver group clinics that will deliver that QoF. Okay, so that's a really important thing to know. But start with one pathway where you've got the biggest challenges around access and workforce, and then move from that to other ones. Sandra from Orpington, that's exactly what you've done, isn't it? You started with menopause, you've gone on to diabetes. Do post into the chat some advice and support for the others on the session. That would be amazing. Okay, We're getting towards the end, so I'm gonna we've just got 5 minutes, see what else. So I'm going to probably have to skip over this one. We've talked about this a lot. So make it something that is a problem solver. That's the key thing, I think, in relation to Headspace. So identify a problem that you've got and then say, right, we're really struggling with this. Let's use group clinics to solve this problem. I think that what helps to create the Headspace. Do you agree, Dipti? Good. Okay, so I'm going to hand back to you now, Alicia, so that you can just tell people about next steps and a little bit more about the training.
Thanks, Georgina. So just to give you guys a heads up, as we've already said during the session, we've released our 2026 webinar program. It's live on our website now at www.elcworks.co.uk. So our free webinar in November, for example, is all around outpatient group clinic models. And in January, we're going to dive into CVD, QOF, and group clinics. So have a look at those, get yourself signed up so they're in your diary and ready